half an hour behind time, but that's okay. Yes, Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to all. Oops, let me turn off my camera, turn on. How are you? After your briefing session, are you okay? Are you more clear about the program?
Yes, Doctor.
Yeah, usually we will have the orientation session to the first day lah, so that you can align your mind and your thoughts into what you'll be expecting lah. But due to some unforeseen reason, you had to reschedule it today. So you already started with classes yesterday, am I right?
Yeah.
Yes, correct.
Was that?
Yes.
Is it okay?
Adjusted.
Research methods kan? Basically research methods. It's okay. You can refreshen up a bit. Yang lama, yang mana-mana lama dah tinggal research tu, I think that it's a good opportunity for you to refreshen balik. So today, you are geared into clinical punya subject. So this morning it will be hypertension by me. Petang Dr. Casey
Yeah, Dr. Casey.
Okay. So I guess course plan pun dah ada kan? You all dah dalam Google Classroom. So course plan tu is your reference document to see what are the subjects that will be covered. Okay, what are the subjects, when it will be covered, and by who. Okay, so untuk my part for this paper 72 ni, I will be handling two topics. Okay, the first one is hypertension, and the second one will be this Friday insyaAllah on AF and DVT. Actually three lah, kita orang terpaksa cramkan a few topics in one lecture because we need to finish most of your lectures cepat so that's why we need to cram everything. So just bear with me. I'll be going things very fast. So if you don't understand, just stop me in between, or you can always refer back to your reference book, to your guidelines. Okay. So for hypertension, I don't know if you've looked at the Google Classroom. I've actually asked you to go through the ESC guideline. So that will be my main reference. Okay, ESC guideline is European Society of Cardiology. Okay, as well as Malaysian CPG. So ESC guideline was published untuk hypertension ni was published in 2018. So it's quite recent. Malaysian guideline pun quite recent lah. Okay. For all the latest update, you can look at those two guidelines. Okay. In terms of reference book, okay, I'll be using pharmacotherapy book. Let me just share with you. Nah, pernah tengok tak buku ni? Pharmacotherapy by D. Piro. Probably you've seen it when you were in undergraduate. Mungkin dah lupa. So this is how this book looks like. Boleh nampak ke?
Yeah, can see.
Boleh nampak.
Boleh nampak.
Yeah. So this is my reference book for for three of the topics that I'll be teaching. Okay. So if you go, okay, hypertension is in section 4. Okay. Have a read because it's quite impossible for me to cover everything in this 2.5 hours, 3 hours. Even we have 4 hours pun, I think you guys will be okay. So read this chapter and tally your mind with all the guidelines that I've shown. Yes, the guideline. Okay, so let's start with the lecture. Can you guys see my PowerPoint?
Yes, Doctor.
Yes.
Right. So for me, when I have sessions with you, I would really love to hear your thoughts along the way. I like a two-way conversation. Not just me presenting, because I think most of you have a lot of experience at your workplace. So I think you guys know better than me. So it's more of a discussion, sharing information. Okay, if I'm wrong, correct me. Okay, whatever that I say that's not aligned with you, just let me know. I'm open to your opinions. Okay. All right. So today we'll be covering hypertension, which is further divided into essential hypertension and severe hypertension. Okay. So this is today's agenda. Okay. So the secret of getting ahead is getting started. Okay, that's the motto for today. So let's just start with the topic, and inshallah we will be okay. So these are the books that I've mentioned, and the CPGs that I will be using in my lecture. Okay, so this is the course objective. Okay, at the end of this course, you should be able to understand hypertension and severe hypertension, identify cardiovascular risk factors, know the classification of hypertension, identify target BP for different groups of population, manage hypertension, okay, and severe hypertension based on patient comorbidities using different classes of drugs, as well as non-pharmacological management. No common drugs in terms of dose, indication, contraindication, side effect. I think this is not a problem for all of you since you've been working for a very long time. Okay, and some important counseling points to patients. So this is my outline for today. Okay, right. So in terms of epidemiology, okay, from the National Health and Morbidity Survey in 2011, the prevalence of hypertension in Malaysia in adults above 18 years is about 33%. Okay, they did the survey in 2006 to 2011, and they found about a third of our patients have hypertension. Okay, and those older than 30 years old, the prevalence is higher, about 44%. Okay, unfortunately, about 61% of the total hypertensive were undiagnosed. Okay, so meaning the moment they know that they have hypertension, it's either they are presented to the hospital with the complications such as stroke, or with heart attack, or with heart failure. So because of that, BP has to be measured at every opportunity that they have, that the doctors have. So like, going for vaccination, we measure their BP so that we can detect earlier rather than waiting for the damage to be done than knowing the patient has hypertension. Okay. No significant difference between gender was observed in this survey in Malaysia. Okay. However, Bumiputera, Sabah, and Sarawak has the highest prevalence, 36.4%, followed by Malays, 34%, Chinese, and lastly Indians. Now, before we move on, so can any one of you tell me what is the cutoff BP for hypertension? I'm sure this is an easy question. Anyone?
Currently it's 140 for the systolic and 90 for diastolic.
Right, thank you very much. That's correct. Okay, so its definition of hypertension is a systolic BP of above 140 and a diastolic BP of above 90. Now, this has to be based on an average of 2 or more properly measured seated BP readings on 2 or more clinic visits. Okay, so it doesn't mean that if a patient has one reading, maybe they come to the community pharmacy, they want to buy a Panadol, check their BP and it's high, just one reading. So it cannot be diagnosed like that. Probably we can let the patient know to go to their physician so to get checked properly, and it has to be based on at least 2 or more readings on 2 or more clinic visits. Okay, it has to be confirmed. Just one reading does not confirm that you have hypertension. Now, there is a positive relationship between systolic blood pressure, diastolic blood pressure, and the risk of developing cardiovascular, cerebrovascular, and renal disease. And hence, the main aim of identifying and treating high BP is to reduce this risk. right? So we're not only treating patients with hypertension to lower their BP, we are treating them because we want to prevent the risk of developing this cardiovascular disease, such as stroke, such as MI, okay, and heart failure. We want to prevent them from getting strokes and renal disease, okay? So, and hence BP should be measured at every clinic encounter. So just a brief pathophysiology of hypertension. I'm not going to go into very detail of this. I will leave you to read on pathophysiology of hypertension from the pharmacotherapy book. But in summary, BP is contributed by your cardiac output and your total peripheral resistance. So cardiac output is the volume of blood pumped by your heart per minute. And the TPR stands for the overall resistance to blood flow through the systemic blood vessel. Okay, so there's various neural and humoral factors that are known to influence and regulate BP, including all of this. Okay, so BP is normally regulated by a compensatory mechanism that responds to changes in cardiac demand. Okay, in a normal person, when there is an increase in your cardiac output, there'll be a compensatory reduction in your TPR, total peripheral resistance. However, there's some problems, okay, any adverse changes to the BP occur when the compensatory mechanism does not function properly. So in hypertension, there is an initial increase in your blood volume, in fluid volume, that's causing increase in cardiac output and arterial pressure. Okay, so if you can see in this diagram here, okay, just have a look. In a normal person like you and me, we have a normal amount of blood in the vessel, and our diameter of the blood vessel is normal, and hence we do not have high blood pressure. Now, when there's too much blood in the vessel, but our diameter is normal, then the risk of you getting hypertension is high. Okay, and when your blood, the amount of blood in the vessel is normal, but then your diameter is narrowed, that is cause your pressures to go up as well. Okay, can you guys follow me so far?
Yes.
Yeah. Yes, Doctor.
Okay. So, and hence, that's why drug treatments are targeted at reducing the cardiac output and reducing the total peripheral resistance. Okay, that's this is a busy diagram on the pathophysiology of hypertension, but basically, like what I've mentioned before, your blood pressure is determined by your cardiac output and peripheral resistance. So what happens is in hypertension, there is an increase in cardiac output and there is an increase in peripheral resistance. So what factors causes an increase in cardiac output? You can see here, there's an increase in preload, which is caused by excessive sodium intake, okay? Now, when patients, usually our patients who has hypertension, when we talk to them, they will say that they like salty food. They like ikan masin, they like, all sorts of salty food. So all this salty food, as you know, as you can remember, salt will retain water, right? So it will increase your fluid volume, increase your preload, and increase your cardiac output. Okay, some other factors like stress, okay, genetic alteration, obesity, these can cause an increase in peripheral resistance. Okay? Now, patients with hypertension, in general, they may appear healthy, okay, or they may have additional severe risk factors. Most of the time, they're healthy. When you talk to them, they say, I'm fine. There's nothing wrong with me, Sometimes they will say they'll have severe headaches, but most of the time they will say that they're fine. Okay, but then they don't know that they have hypertension. Okay, or they may have additional severe risk factors. So these risk factors, for example, age, as you grow older, especially more than 55 years for men and more than 65 years for women, your risk of getting hypertension is higher. Okay, diabetes, dyslipidemia, albuminuria, family history of premature cardiovascular disease, okay, overweight. Right, guys, can I have an important call. Can I just pause for 1 second?
Okay, sure.
Sure, Doctor.
Sure, Doctor.
Right, sorry. Just continue. All right. So where was I? Was it this slide? Okay. Right. Additional CV risk factors. So what was I? Was that overweight, right? Yeah, overweight, obesity, physical inactivity, tobacco use. Okay. So these are all additional risk factors that will put a patient at risk of having hypertension and cardiovascular diseases. Okay. Like I said, symptoms are usually none related to elevated BP. So by the time they know that they have hypertension is when it's usually incidental finding when they come for another problem, but they noted that their BP is high. Okay. Now, this is the classification of blood pressure according to the Malaysian CPG 2018. Okay. I think everybody knows a normal blood pressure is less than 120/80. Okay. Prevalence is quite high in Malaysia. We have about a third of the patients in the normal category, optimal category, sorry. And then you have your normal category, you have your at-risk category. Okay. Now, the minute you have hypertension, stage 1 is when your BP is above 140/90, like what I think Zubaida has said just now, right? So if your BP measurement is above 140/90, you are considered in stage 1 hypertension. Okay. Now, if your BP is above 160/100, you are in stage 2. And when your BP is above 180/110, you are in stage 3, or also known as severe hypertension. Now, the way to remember is when you have stage 1 to stage 2, there's about 20 millimeter mercury difference between stage 1 and stage 2 for the systolic, and 10 millimeter difference between the diastolic. Okay, so just remember stage 1 is above 140/90, stage 2 is above 160/100, and stage 3 is above 180/110. Okay, so similarly, the ESC guideline has also staged the classes of hypertension similar as with Malaysian guideline. Okay, class 1 is above 140/90, class 2 is above 160/100, and class 3 is above 180/110. Now, why it's important for you to remember is because treatment depends on which stage the patient is at. Okay. Now, we also have this term called isolated office or white coat hypertension. So, who can tell me what does that mean? What does a white coat hypertension means? Hello? Hello? Anyone?
Yeah, Doctor.
The BP is normal at home, but when the patient came in, it tends to be higher.
Yeah, that's right. Thank you. Thank you for answering. I can't see who's answering because with Mac, if I'm already sharing the slide, I mean this presentation view, I can't see who's speaking, unfortunately. But thank you for the answer, and you're right. Okay, that means your BP is consistently high in the clinic, but normal at other times. Okay, that's a white coat hypertension. Okay, so we also have this term called isolated systolic hypertension, whereby only your systolic BP is high, is above 140, but your diastolic is normal, is less than 90. Okay, so treatment is effective at reducing cardiovascular risk. Now, these are the things that you can use to measure your BP. Okay, you have your mercury column sphygmomanometer, which I don't think we use this anymore. You have this electronic BP set, which I think majority of the doctors are using, as well as the pharmacy, as well as us at home with our parents. We have this, that's good. Or we also have this ambulatory BP set. Okay, this is usually used in patients whereby when the doctors wanted to know their BP reading for at 24 hours, 48 hours, we ask the patients to put on this BP set throughout the whole day, throughout the entire duration that we want to know dia punya BP. Okay, except when they're showering lah, tak adalah, okay. Right, so it will give some information about your BP during daily activities and during sleep. Okay, right, so in terms of diagnosis and assessment, okay, the objectives of evaluating patients with documented hypertension is first to exclude secondary causes of hypertension, to ascertain the presence of or absence of target organ damage, and to assess lifestyle and identify other cardiovascular risk factors or concomitant disorders that affect risk factors, prognosis, and guide treatment. Now, who can tell me what are the example of secondary causes of hypertension? Anyone?
Pregnancy.
Okay, right, pregnancy. Lagi?
Hypothyroid.
Hypothyroid, yeah. Lagi?
PIN,
Tak dengar.
procedure,
Procedure, yeah. Procedure, usually it does not lead to a proper diagnosis of hypertension. You can have an elevated BP due to pain, but then after that it will go back to normal lah. Okay. So example of secondary causes of hypertension are like the sleep apnea, drug-induced or drug-related, okay, chronic kidney disease, primary aldosteronism, renovascular disease, pheochromocytoma, chronic steroid use, acromegaly, hyperthyroid, okay, or these are example of secondary causes of hypertension. And then when we assess the patient at the first, not we, the doctors, when they assess the patient the first time, they want to know whether the patient has any of these following condition or not. Okay, if they do have this, of course they will have to address these issues first. Okay, sleep apnea, CKD, and so on and so forth. Okay, that is the secondary causes of hypertension. Now, in terms of target organ damage that I've said just now, for example, at the heart, it can cause heart failure, right? Coronary heart disease, left ventricular hypertrophy. At the brain, it can cause strokes, dementia. At the peripheral vasculature, it can cause intermittent claudication, okay, or AAA, abdominal aortic aneurysm. It can also cause kidney disease, okay, macroalbuminuria, proteinuria, or it can cause exudates at your retina, hemorrhages or exudate. So when they assess the patient at the first time, they have to look for if the patient has secondary causes of hypertension or if they already developed the target organ damage. Or also we call it target organ complication. Now moving on, going back one slide. Now apart from that, they also do a complete history, physical examination, and initial investigation. Okay, like complete history, you know, they ask the duration of high BP, how long the patient already have high BP, secondary causes of hypertension like we've seen just now, symptoms of target organ damage, whether the patient has concomitant disease, because why they have to assess all these things, because treatment will depend on these factors, okay. Then they also do physical examination, like height, weight, waist circumference to look at your BMI. Okay, fundoscopy. Why do we do fundoscopy? Anybody knows?
Because high BP will technically affect the optic nerve of the patient.
Yes, that's right. Yeah, and if the patient has high BP for a prolonged time and underdiagnosed, they can have retinal hypertensive retinopathy. Okay, so that's why they check your eyes to make sure that it doesn't go up to that extent yet. Or if it does go to that extent, that means the patient already has target organ damage, like what we've seen in the next slide here. Macam ni. Okay. Also investigation, full blood count, urinalysis, lipid profile, RP, fasting blood sugar, of course, because they want to know whether the patient has underlying diabetes or not, CKD or not, lipids, HDL, LDL, normal or not, urinalysis, of course, when you look for whether the kidneys are functioning properly or not. All right, so 50%, half of the patients with essential hypertension did not have their cardiovascular risk adequately assessed. Following initial clinical evaluation and investigation, patients should be risk stratified. So what do I mean by risk stratified? I will let you know after this. Okay, so many patients with hypertension, they have more than one other cardiovascular risk factors. Okay, each additional risk factor increases your cardiovascular risk substantially, and hence the overall global cardiovascular risk of a patient with hypertension, it should be done. So how do we do that? Okay, there are several calculators. You can use the Framingham General Cardiovascular Risk Chart, or you can use the risk stratification table. Okay, so I have an example of a risk stratification table from your Malaysian CPG. So let's look at this chart, okay, one by one, right? So we know that patients with hypertension, their systolic BP is above 140/90. Is that right? Okay, so if they don't have any risk factor, they don't have any target organ damage, you see they're at the low risk. So what does low risk means? It means that the risk of the patients having a major cardiovascular event in 10 years from now is about 10%. So we advocate healthy lifestyle first. Okay, but then as you move across the table, if the patient has target organ damage, or if the patient has risk factors, one or two risk factors, the patient is at medium risk already. That means the risk of him having cardiovascular event in the next 10 years increases from less than 10% to between 10 to 20%. That's why when the doctors are speaking to the patient, they have to let the patient know about this, because if not, the patients will be very hesitant to take their medication, because they will say, come on, I don't have any symptoms, I'm okay, I'm fine, it's just that my BP is high, maybe because I'm stressed, I don't want any medication. So we have to let them know, if they're in the medium category, they have risk factors such as, who can remember just now, what are the risk factors?
Your family history.
Yeah,
High cholesterol.
yes, they have
Smoking status.
yes,
Smoking, alcohol consumption.
yes. So majority of our patients actually are in this category, medium already. They already have one or two risk factors. And if they're lucky, they're already developed target organ damage. They have to start treatment straight away. How we want to how to pujuk them by telling them this lah. Okay, if you don't take any treatment, in the next 10 years, in 2031, you might have, a cardiovascular event. You might have a heart attack. You might have heart failure if you don't start treatment. So by telling them this, it is hoped that, they would want to start treatment. Okay, and of course, if you have target organ complication, or you have more than 3 risk factors, your risk is high. So high, that means you have a 20 to 30% risk of having cardiovascular event in 10 years. You have to start treatment straight away. And if the patient in stage 1 already have a previous, this is the worst case, they have a previous heart attack, okay, MI, or previous stroke, or they already have diabetes, they're at the very high risk, more than 30% increased risk of cardiovascular event in 10 years. So these are the patients that we really have to look very carefully lah, in the very high risk ni. Hopefully, none of our family members are in this category. Kalau in this category, lagi senang to develop cardiovascular events. Right, so this slide shows a summary of the office BP threshold for treatment. So what I mean by threshold for treatment, it means that when you need to start treatment. Okay, so in most of the patient, of course, you need to start treatment the minute the patient has a BP of above 140/90. However, in the very elderly patients, okay, what I meant by very elderly, those above 80 years old, 80 and above, we usually start treatment when their BP is above 160/90. This is based on the new guideline, okay? Because they have seen evidences that in very old patient, the more strict that we are with BP reduction, the patients has more harms. So they make it very lenient for those above 80 years old. I think dekat Malaysian population ni jarang kita nampak patient above 80, betul tak? Our population yang kita selalu nampak is between 60s, 70s. Yang nak survive above 80 ni sangat kurang. Betul tak? Am I right?
Yes, yes, Doctor.
Yeah. They will die before they reach 80 because either their underlying problems are not well managed. So susah nak cari patient yang above 80 ni. This is more towards population dekat Western countries where their lifespan is very long because these patients they have, how do I say this? They have more awareness, they have more responsibility towards their own self and towards managing their diseases. So fortunately, they live longer than us. Their lifespan is longer compared to Asian population. So sebab tu diorang buat this recommendation lah, because those people yang come up with the guidelines are the European. Kita Malaysia usually we follow je lah what the Europeans did. Okay. Now, similarly, okay, this is the threshold for treatment with the level of evidence. Okay, 1E is the highest level of evidence, like I've said just now. In majority of the population, when your BP is above 140/90, you can start treatment. Whereas in those above 80, you start at 160/90. But then, in those with very high risk factors, you can consider starting treatment a bit earlier when the BP is above 135/85. But this has a level of evidence to be A. 1A ni is the highest level of evidence lah. Class 1A, paling tinggi lah kalau you tengok dalam guideline. So kalau kita nak tengok recommendation, usually kita tengok yang 1A ni lah. Okay, this is the gold standard. Right, so are you guys okay? Shall we, are you guys okay to continue before we dwell into management of hypertension, or do we want to take a break?
Yes.
I think we good.
Boleh eh?
You do.
Any questions before we move on? No. Okay, so management of hypertension can be divided into two, as you would have known. We have your non-pharmacological management, you have your pharmacological management. So when we are doing counseling to our patients, we do both, okay? Not only we tackle the pharmacological part, we also want to advocate the patient at the non-pharmacological management as well, not just pharmacological management. Now, so this is a patient care process. It's a process that I gathered from your pharmacotherapy books. What do we do when we see patients with hypertension? So we are putting the patient we are treating the patient as a center, okay? Patient-centered care. So what we do, first we collect information. That's what we did. That's what we've discussed just now. We collect whether the patient punya characteristics, okay, family history, BP reading, and then we assess the patient. Okay, we look at whether the patient has compelling indication, okay, whether the patient has related complication. We look at their 10-year risk, okay. We look whether they have any medication that can contribute or worsen hypertension. Who knows what medication can contribute or worsen hypertension? For example, anybody? Anyone?
OCP.
Yes, that's right. OCP, very relevant. Yes, especially which type of OCP?
The combined OCPs.
You sure, or is it the estrogen OCP?
But the estrogen's more predominant.
Yeah, I think the estrogen-based OCP has higher risk of high BP. Okay, anything else?
Your
Yes.
SSRIs.
Yes, steroid, SSRI. 'Cause sometimes your prolonged NSAID use can also increase your BP. So these are the things that we need to look when we are counseling the patients. Okay, and then of course we need to tell them the BP goal. Okay, because when we want to start treatment or we want to do anything, in fact, in life, we need to have a goal, don't we? Right. So similarly to patients, when we talk to them, we need to tell, look, Mr. Ahmad, your BP is 170 over 140, for example. It's very high. You are in this stage of hypertension. Now we are giving you treatment so that you can achieve your goal. So what is your goal? Of course, you want the BP to be less than 140/90. So they need to know that. So we need to let them be in charge of themselves. So they know what is the consequences of not getting their BP under control, of not taking the medication. So bila kita empower patient ni, they can be more, how do I say this? They can be more in charge of themselves. That's what I see happening in the overseas. Okay, I have patients in my studies that are above 80 years old. When I see them, it's amazing. They are willing to come and see me naik bas, turun bas dengan tongkat 4 tu. Just to be in my study to help me. And then when I speak to them, they are very knowledgeable about the disease and they take care. They're in charge of themselves. They know if they don't take this medication, this will happen to them. I cannot see my grandsons, in 10 years' time. I cannot go to their birthday party. So they are very motivated. They have something to look forward to. So I know it's difficult to do that with our patients, but I don't know. We need to start somewhere, right? So, because I've known patients, Malaysian patients as well as Western patient, different characters. But I guess we need to start somewhere lah. Kalau tak sampai bila-bila we cannot change. Okay, then once we already assess them, we need to plan. Okay, what do we want to do? Okay, that's why we need to ask them makanan dia macam mana. Okay, is it very excessive in salt? Okay, is it excessive with fried food? Okay, and then what about the exercise pattern? What is their weight? Okay, and then we can start designing the therapy lah. Okay, and then what to monitor, right? Patient education, and so on and so forth. Okay, then once we've planned, of course we need to do it lah. Okay, not only we plan, but we do it. Okay, I think most in MTech, most of the things that we do macam ni lah kan, kita dah plan apa-apa, and then we call the patient, and then we start doing what we've planned, and then we follow up the patient. Janganlah kita dah plan and everything, and then we just leave the patient. Tu tak bagus lah kan. Of course we need to sentiasa follow them up to see whether whether their BP goal has been achieved, whether the patient has any side effects from the medication, whether the patient has cardiovascular events, okay, or progression of kidney impairment. Of course, we don't want that to happen. All right, and this we have to collaborate with the patient, with the caregivers, and other healthcare professionals. Okay. Now, non-pharmacological management. Okay, there's a lot. Okay, there's weight reduction, regular exercise, sodium intake, blah blah blah. Okay, when you have when you have questions in essays for your final examination, don't just put all this point lah. I would expect you to elaborate a little bit more, if the question asks any non-pharmacological management. For example lah, I'm telling you, for example. So when you say weight reduction, berapa? How much weight do you want to reduce? Reduce sodium intake ni how much? So kat sini dah ada lah. Salt restriction to less than 5 gram per day is recommended, and that's a class 1A evidence, okay? In terms of alcohol consumption, you need to reduce it at least less than 14 units for men and less than 8 units for women. This is especially to non-Muslim patients. Okay.
Doctor, what units mean?
Unit. So unit tu dia ada chart dia. Bukan satu unit tak bermakna satu gelas. Dia ada satu chart. There's a specific chart for alcohol beverages, and the different type of alcohol beverages tu pun bergantung. So chart tu sangat berguna, dia ada gambar berapa besar cawan tu, jenis apa alkohol tu, it is equivalent to what you need. To be honest, I pun tak ingat. Whenever I counsel my patients dulu, I will bring that chart and I will ask them, okay, how much of brandy are you taking, for example? How much of wine are you taking? So you need to have less than 14 units for men and 8 for women. I will bring that chart with me lah. Sebab kita, we are not consumers of alcohol. So we can't remember. I don't know, at least for me lah. I don't know for you guys. So that's what I did lah. Okay. Recommend to avoid binge drinking. Okay. Increase consumption of vegetables, fresh fruits, nuts, unsaturated fatty acid. So semua ni ada level 1A evidence. Okay, body weight to avoid obesity. What do you mean by obesity? BMI of above 30. Okay, and aim at healthy BMI. Okay, exercise pun, bila kita cakap exercise pun kita kena beritahu lah kat patient. What do you mean by exercise? Okay, at least 30 minutes of moderate dynamic exercise on 5 to 7 days per week is recommended. Okay, and smoking cessation also level 1B evidence. Okay, right. So far okay?
Okay.
Doctor.
Okay. In terms of pharmacological treatment, okay, like I said, before we initiate any treatment, we need to tell the goal. Okay, so that the patients know what are they aiming. Okay, kalau kita tak beritahu goal, it's like macam kita lah kan, in our life, if we don't have a goal, kita tak ada arah, betul? We don't know where to go, we are terhoyong-hayang all the time. But if we have a goal, we are a bit directed towards achieving that goal. Although it's not easy, but at least we have something to look forward to. So we need to tell the patient the overall goal of treating hypertension is to reduce morbidity and mortality from CV events. So for example, apa CV events? Like your coronary events, like I said, like your heart attacks, your heart failures, okay? Cerebrovascular events such as stroke, okay, and kidney disease. Kita kena bagi tahu kat patient, we are not just treating you punya hypertension to reduce you punya BP reading, no. We are treating you to prevent you from getting further complication from hypertension. Yeah, I know it's not easy. Even with parents, I'm fighting with them all the time because they would say that, I'm fine, my BP is okay already. Why do I need to take this medication? Okay, why are they adding up more medication? We need to tell them it's not about your BP reading alone. It's about preventing you from getting further problems down the line. Okay. specific selection of antihypertensive drug therapy, it should be based on evidence demonstrating a reduction in morbidity and mortality, not merely a reduction in BP. So like I said, kita select antihypertensive drugs tu bukan sahaja untuk nak reduce dia punya BP, but it must be evidence based to reduce morbidity and mortality. Okay, and treating patients with hypertension to achieve a desired goal is a surrogate goal of therapy, meaning surrogate goal tu dia memang kita aim to reduce BP level dia, tapi dia bukan our end goal, dia macam intermediate goal. Okay, and reducing BP to goal does not guarantee prevention of hypertension associated complication, but is associated with lower risk. So biasanya targeting a goal BP is how clinicians evaluate response to therapy. Contohnya first time kita jumpa patient, BP dia tinggi, 160/90. Of course kita start treatment, the next visit kita would expect dia punya BP to reduce lah. Betul tak? Kalau dia compliant lah. Kalau dia tak compliant, kalau dia compliant dan BP dia still tinggi, of course we want to adapt therapy. Okay, it's the primary method that is used to determine the need for titration and regimen modification. Okay, so like I said, we need to have a goal. Okay, so in majority of the patient, okay, less than 65, we want to target to lower your BP to 130 or lower if tolerated. Okay, 130 systolic and diastolic between 70 to 79. Okay, clear? So maknanya kita nak target dia punya BP less than 130, okay, or lower kalau tolerated, systolic, and then diastolic dia between 70 to 79. In patients 65 to 79 years old, we want to target dia punya BP in this range lah, between 140 to 130, tak low sangat. Okay, sama juga dengan above 80. Okay, are you guys clear with me?
Yes, doctor.
Right.
Yes.
So this target range ni, it has a 1E level of evidence lah. Okay, bukan saja-saja je lah kita buat all this recommendation, it's based on level 1A. So between 80 to 65, like I said just now, okay, kita aim to less than 140. Okay, kalau boleh, kalau tolerated below 130 lah. Okay, macam tadi lah. Okay, tapi not less than 120/80. Kalau you tengok it's in red, not less than 120/80. Okay. Now, so how do we initiate BP lowering treatment? Okay, so this slide shows you initiation of BP lowering treatment at different initial office BP level. So that's why I said it's important for you to know at which stage the patient is at. Okay, grade 1 ke, grade 2 ke, grade 3 ke, because your treatment depends on which grade you have. Of course, when you have high normal BP, you in borderline lah, okay, between 130 to 139, systolic, diastolic 85 to 89, you would advocate lifestyle advice first. And then, but then you consider drug treatment in very high risk patients, especially yang ada CVD, okay, or coronary artery disease. Now, when you are in stage 1 hypertension, okay, the minute you are in stage 1, of course, in all stages of hypertension, we advocate lifestyle advice. Okay, in grade 1, you need to start treatment straight away in patients yang in high or very high risk, especially those with cardiovascular disease, renal disease, or HMOD. But in patients yang ada in the low to moderate risk, okay, and without cardiovascular disease or renal disease, okay, after 3 to 6 months of lifestyle intervention, so meaning kita in low risk patient ni kan, kita advocate dia lifestyle intervention dulu 3 ke 6 bulan. Kalau tak jalan, after that baru kita start treatment. Okay, maknanya patient yang solely has hypertension alone without any other disease, kita bagi lifestyle intervention dulu 3 to 6 months dan baru kita start. However, kalau dia dah in the category yang high or very high risk or ada cardiovascular disease dunia, kita start treatment straight away lah. Okay. Grade 2, grade 3 pun start away lah, immediate drug treatment in all patient. Straight away. Kalau you tengok sini semua immediate. Okay, grade 2, grade 3 ni kita tak tunggu-tunggulah, straight away kita dah kena start. Cuma grade 1 saja kita bagi 3 to 6 months lifestyle advice kalau dia in the low to moderate risk. So that's why tadi awal-awal I cakap it's important for you to stratify your patient tu macam mana. Okay, because then baru kita boleh identify what do we need to do with the patient. Okay, so so this is according to the ESC guideline. Okay, prompt initiation of BP lowering drug treatment is recommended in patients with grade 2 or 3 at any level of severe risk. Okay, a class 1A. However, in patients with grade 1 hypertension, lifestyle intervention are recommended to determine if this will normalize BP. In patients with grade 1 hypertension at low, moderate risk and without evidence of these things, we recommend healthy lifestyle. Ni macam yang I cakap tadi lah, right? But ada level of evidence lah kat sini. Okay. Yang patients yang grade 2 and grade 3 pun macam ni lah with all the evidence kat sini. You can have a look after this. Now, so this algorithm, it shows what do we need to do with the patient. Okay, so kalau stage 1 hypertension, macam tadi I cakap lah, kalau tak ada masalah apa-apa, we go lifestyle modification and we reassess 3 to 6 months. Okay, kalau patients ada diabetes, CKD or risk score of more than 10, okay, although we advocate lifestyle medication, kita still kena start with the treatment straight away lah. Okay, if the patient has no compelling indication, we can start with monotherapy. Monotherapy, you can start with an ACE, with an ARB, CCB or thiazide. Okay, maknanya kalau patient tu hanya ada hypertension sahaja without any problem, tak ada masalah apa, hanya hypertension, kita nak start dengan apa? We start with monotherapy with either this agent, ACE, ARB, CCB or thiazide. Then we reassess in 1 month. Okay, but once the patient is in already stage 2, we need to start dual therapy lah. Okay, like this. Okay, you need to start initial therapy dual combination kalau patient dah ada these problems. Okay, cerebrovascular disease ni contohnya stroke, diabetes or PAD. Straight away dia kena start dual combination. Tak boleh start single lah. Single tadi hanya monotherapy ni, okay, consider monotherapy in low risk grade 1 hypertension. Maknanya yang low risk ni kan macam kita tengok tadi, low risk are those without any risk factor, hanya ada hypertension sahaja problem dia. So that we can start with one agent. But the minute they have other problems, okay, HMOD is hypertension mediated organ damage. Okay, you can carilah what are the examples of HMOD. Okay, or stroke, diabetes, PAD, dah start kena dual therapy. So what agent do we need to combine dual therapy ni? So kat sini ESC guideline dah nicely illustrate. Okay, you can start with an ACE, okay, or ARB. Okay, so you tutup dulu OR ni, kadang-kadang sebab student selalu cakap dia confused dengan OR ni. Okay, let's say you want to choose ACE. Okay, in your head you just want to choose ACE. Okay, fine, that's fine. ACE plus a CCB. Okay, for example your perindopril plus amlodipine. Ataupun perindopril plus a diuretic. Contohnya HCTZ. Okay, to dual combination. Okay, so katakanlah dual combination ni tak jalan, you need to start with triple combination. So triple combination tu must have an ACE, a CCB or a diuretic. Okay, selalunya ARB ni kita bagi kalau patient ni tak boleh tolerate ACE lah due to ACE-induced cough ke kan. Sebagainya baru kita bagi ARB lah kalau kat KKM lah usually. Right, so kalau dah 3 agent tak jalan, triple therapy is not working, we need to go to step 3, triple combination plus a spironolactone or other drugs. Okay, maknanya this combination 3 ni campur a spironolactone. Now as you can see, beta blockers tak ada kat mana-mana kan? Betul?
Ya, betul.
So you only consider beta blockers at any treatment step when there is a specific indication for their use. For example, heart failure, angina, post-MIEF, or younger women with or planning pregnancy. So beta blockers is no longer used as a first line kalau patient tak ada any indication for it. For example, heart failure, angina, MIEF. Kalau dia tak ada diseases related to the heart, kita tak bagi beta blockers as a first line. Okay? Faham?
Faham.
Right, kita bagi benda lain dulu. Why? Memang ada banyak studies and banyak evidence have shown that beta blockers is beneficial in patients with underlying heart disease. So heart disease contohnya heart failure, MI, AF, then baru kita letak beta blockers as first line. Nanti you akan nampak in the next slide. Okay, contohnya ni lah. Okay, drug treatment strategy for patient yang ada hypertension and underlying coronary artery disease. So you nampak kat sini baru you nampak beta blockers ni kat sini. Kalau dia ada underlying heart disease, baru you start with ACE plus beta blockers. Sama jugalah dual first, and then tak jalan triple, tak jalan triple plus spiro. Okay?
Okay, doktor.
Right, so kalau patient ada hypertension and underlying CKD, also you need dual combination, okay, and ACE plus CCB, okay, ataupun ACE plus diuretic, okay. So again, dia highlight kat sini, consider beta blocker at any treatment step when there is a specific indication for their use. For example, kalau patient ada heart failure, ada heart problem lah. Kalau tak ada, you don't need to add beta blockers as a first priority. Okay, okay. Patients with hypertension and heart failure with reduced ejection fraction. Okay, siapa tahu reduced ejection fraction berapa dia punya value? Apa maksud heart failure with reduced ejection fraction? Anyone?
Ejection dia less than 40%.
Yeah, less than 40%. Okay, so that is reduced ejection fraction. So kita ada reduced ejection fraction and we have heart failure with preserved ejection fraction. Preserve meaning dia punya echo result is above 40 lah. Okay, so yang ni kita kena start dengan triple therapy lah kalau you perasan. ACE plus diuretic plus beta blocker. Okay, first line dia memang terus 3. And then kalau tak jalan baru we need to add MRA. Siapa tahu MRA apa?
Spironolactone.
So it stands for mineralocorticoid. Nak sebut pun tak erti ni. Right. So for heart failure ni memang 3 lah. Okay. Of course ACE dengan beta blockers it has motility benefit and your diuretics is to remove the excessive water due to the heart failure. Okay. In AF, okay, drug treatment strategy for AF, patient with hypertension in AF. So again, you start off with dual combination, okay, with your ACE plus beta blockers or a non-dihydropyridine CCB. Contohnya apa non-dihydropyridine CCB ni?
Verapamil.
Verapamil dia.
Yeah, verapamil diltiazem. So these are the only times that you use those non-dihydropyridine CCB in patients with AF lah, okay. Because this non-dihydropyridine it has sorry bising saya dekat library. It has the apa ni ability to reduce your heart rate juga, okay. Other times kita use your dihydropyridine lah, contohnya amlodipine, okay, felodipine. Right, so kalau tak jalan again, you combine lah triple therapy, ACE plus beta blocker plus dihydropyridine CCB or diuretic Okay. Yang O ni kan korang jangan confuse tau. Dia macam ni. Kalau korang nak tahu triple combination ni, you tengok the first apa ni? The first recommended agent, and then dia add apa? Beta blocker. And then dia add apa benda? Atau diuretic. Okay. Lepas tu ini dah settle satu part. The other one or beta blocker plus ni plus diuretic. This is the second regimen yang diorang recommend lah. Okay, so you kena tengok yang tambah-tambah ni kat mana and then apa agent sebelum dia. Okay, clear? Sebab I tak tahu lah budak undergrad selalu cakap dia confused. But I guess for you guys dah biasa kan, you dah selalu tengok patient-patient dekat hospital. So I guess it's not confusing for you guys lah. Kan? Alright. So these are the summary of what are the things that you can, what are the agents that you need to give based on dia punya underlying problems. Okay? Summary sajalah. Okay, so since you guys are at the master level, so we have to look at the evidence. Where are the evidence supporting the treatment? This actually is a summary of major drug combination used in trials of antihypertensive treatment in a step approach or in a randomized combination. So for example, I takkan go through semua lah. Nanti you all, pingsan pula kan? So for example, I just go through one trial ni je, nama progress trial ni, okay, it's a trial where they use ACE inhibitor and a diuretic combination. They compare with placebo. So siapa patient yang diorang study is those with previous stroke or TIA. So in that progress trial, they can see that there is a 9% reduction in the SBP, and there is a 28% reduced risk of stroke. So kat sini, what I'm trying to say is this is how they come up with recommendations based on the guideline. Kalau you remember tadi, when we look at the first slide, kat sini patient with cerebrovascular disease, they recommend an ACE plus CCBO diuretic. So dalam progress trial tu, they start off with an ACE plus a diuretics. So in that trial, what they found out is that, okay, patients with underlying stroke had a benefit in terms of BP reduction as well as reduced risk of stroke by 28%. This is a lot. So that's why they come up with that recommendation. So this is a study, okay, the progress trial. You can find the article here. It's published in the Lancet. As you can see, they recruited over 6,000 patients, okay, from Asia, Australasia, Europe, okay. So patients were randomly assigned either to active treatment or placebo. So active treatment dia mengandungi perindopril plus indapamide, okay, compared with placebo. So what they found out is at the end of the trial, okay, they followed the patient for 4 years. And what they saw was BP was reduced by 9 millimeter mercury, and there is a risk in reducing the risk of stroke. So that's what we want. Bukan saja kita nak treat the patient to optimal BP, kita nak tengok apa effect dia in terms of cardiovascular event. Macam ni, because patients have underlying stroke, of course, the main aim is to look at the risk of future stroke lah. In this case, reduced by about 28%. Okay, so hence that's why this blood pressure lowering regimen reduce the risk of stroke among both hypertensive and non-hypertensive individual with history of stroke. So that's why they recommend, and that's how they come up with recommendation dekat guideline. So this is just showing you these two patient population. Okay, satu placebo, satu lagi yang yang receive this combination lah, perindopril and indapamide. As you can see, there is a reduction in the risk of stroke about 38%. 28%. Yang kuning ni yang kita nak lah. Alright. So there are other trials that supports the evidence. Okay, contohnya macam advanced trial, dia tengok patient population yang has diabetes. So dia tengoklah ACE inhibitor plus diuretic, of course there is a reduction in BP less than 5.6, and the events pun reduce the risk of micro and macrovascular events by 9%. So these are all the important trials that is that is used in hypertension. Okay, so diorang tak buat recommendation atas angin lah, so it has to be evidence based. Okay, you can have a look lah at all this trial if you want. Okay, yang ni compared to placebo. Yang ini comparator dia is another agent. Contohnya in accomplished trial, the compared is inhibitor plus diuretic with ACE inhibitor plus CCB. Hypertensive patient with risk factor, tapi there is an increase in BP pula, more 1 in patient yang ada is plus diuretic in this group of patient, and there's banyak pula event. So what they're trying to see is ACE inhibitor plus diuretic ni tak berapa cantik lah dia punya result compared to ACE inhibitor plus CCB. Okay, accomplished trial ni macam ni lah. In accomplished trial, what they're trying to see is ACE inhibitor plus CCB combination ni is better rather than ACE inhibitor plus diuretic. That's what they're trying to say in accomplished trial ni. Kalau you tengok at the other end lah, less than 21% CV events. Okay. So these are other trial lah, okay, other major hypertension trial. So because of that, dia ada banyak, they cannot specifically say which combination agent is good for which type of patient. So that's why dalam dia punya recommendation, kalau you orang tengok ni, semua ada or ni. Dia tak ada a specific guide say kalau you ada DM, you need to give, kalau patient ada hypertension plus DM, you need to give this plus this. Tak. That's why dia ada or ni, because of the different results in the trial. So that's why they give a freedom for you to choose lah mana combination yang you nak and whether the patient has achieved the outcome or not. Okay guys, are you guys with me?
Yes.
Yes, doctor.
Yes, doctor.
Alright, so of course, you know, if patients are on specific antihypertensive agent, contohnya your beta blockers, you need to be caution, okay, if they have underlying asthma, COPD, dia caution saja, dia bukan a total contraindication, okay. So maknanya kalau patient tu datang with MI contohnya and dia ada underlying asthma, kalau asma dia tak teruk waktu tu, maknanya dia tak ada exacerbation of asthma plus MI, we can safely continue beta blockers lah. Kalau dia ada exacerbation of asthma, at the same time dia ada MI, of course we tak nak bagi beta blockers at that time only. Okay, bila dia dah agak bertenang sikit, then we can continue beta blockers lah. Okay, and then there's the risk of developing diabetes compared with ACE inhibitors. Okay, it may mask some sign of hypoglycemia. Okay, you boleh baca lah yang ni the specific antihypertensive agent ni. Like thiazide, it can worsen gout by increasing serum uric acid. So contohnya kalau patient ada underlying gout yang tengah teruk, tak adalah kita nak bagi thiazide kan that time. So we give something else, bila dah jalan, dah okay dia punya gout, baru we can consider this agent lah. Okay. Okay, with ACE, okay, it's contraindicated in pregnancy, okay, also contraindicated with bilateral renal artery stenosis. Of course, I think most of you know with ACE we need to monitor potassium, okay, especially if the patient is also taking another potassium sparing drugs like your Spiro, okay. So these are the things yang kita nak tengok lah. Okay, Aliskiren is a new drug. I'm not sure, ada ke dekat KKM? Mungkin kotak item kan? Ke tak ada? Aliskiren ni. Hello?
Klinik kesihatan setting tak ada?
Yeah. Mungkin
Hospital saya tak ada.
sedang ada kot. I'm not sure ada ke tak. But it's a new agent, okay. Whether combination is superior to ACE inhibitor plus ARB combination is questionable. Okay, it's a direct running antagonist, okay. When combined with losartan in patients with hypertension, type 2 diabetes and nephropathy, aliskiren showed renal protective effect independent of its BP effect. Kita jarang gunalah ni aliskiren ni, memang tak jarang pun guna. Okay, consideration with specific patient population, patient with ischemic heart disease, okay, potent vasodilators like your hydralazine, minoxidil, it can cause reflex tachycardia, okay, ni pun kita jarang guna lah, patient with ischemic heart disease memang tak guna pun your ni, hydralazine, minoxidil ni, okay. You can also attenuate this by using EV noodle depressant ni, okay. Ini baca lah. Elderly patient, you need to be cautious with agents yang can cause orthostatic hypertension. So you need to initiate low dose and titrate slowly. Pregnant woman, okay, kita tak bagilah ACE. So that's why bila kita assess the patient, we need to ask them whether they're pregnant or not, whether they're planning to have a family or not. So kalau dia on ACE, we need to stop the ACE and switch to other agent yang can be safely initiated lah, like your methyldopa hydralazine. Right, so bila kita dah start treatment, of course we need to monitor the patient, okay, don't just leave them lah, okay. So monitoring can be done in 4 weeks time to assess efficacy of the drugs, okay. You may need to monitor the patient sooner if the BP is skyrocket high, or if there is an inadequate response from the first agent. Okay, so habis essential hypertension. It's almost 12 o'clock. Shall we take a 2 minutes break before we move on to severe hypertension? Boleh tak?
Okay.
Okay.
Right. Shall we continue?
Boleh.
Itu sekarang siapa?
Okay, doktor.
You all semalam 3 jam straight ke kelas pagi dan petang? Ke
Pagi pukul 9 sampai pukul 11.30 macam tu. Petang pukul 2.45 sampai pukul 4.30 juga.
2 jam lah lebih kurang.
Ya.
Ini satu topik boleh tahan lagi. Saya tak tahulah nanti hari Jumaat ni. 2 topik. Aduh. EF dengan DVT. So, you sabar je lah Probably kadang-kadang dalam kelas, you know, when ada benda tak faham tu is quite normal lah. So, you know, balik nanti baca, duduk bertenang, tengok balik guideline, tengok balik reference books, baru it makes sense. Okay? Yang ni satu topik boleh tahan lagi lah. Bila dah 2-3 topik combine ni, tabah je lah
Doktor, saya ada 2 soalan berkenaan lecture tadi.
Boleh?
Tadi berkenaan patient yang lebih umur 80 tahun, kita supposedly to initiate treatment once dia punya BP is 160 for systolic. Don't we have to aware dia punya target organ damage sekiranya kalau tak initiate treatment?
That's a very important question and very, I rasa is very important lah. Okay, so kalau you see, in patients who are above 80 years old, kan, they are very elderly patients. Okay, so we need to have a think in this group of patients, apa yang kita nak prioritize? Okay, how long do we want them to live further? Okay, so although the recommendation cakap we can start treatment bila BP dia above 160 over 90, okay, some physicians, okay, this because guidelines are guidelines, correct?
Yeah.
It's just a recommendation. So recommendations are made based on evidence. So evidence have shown that in patients yang above 80 ni, dia ada banyak risk, banyak harm lagi kalau kita agresif dengan orang because of the risk of orthostatic hypertension, the risk of fall. Bila kita agresif dengan orang, mereka with antihypertensive treatment, dia banyak harm lagi. Tentunya dia senang terjatuh. Kalau orthostatic hypertension kan, hypotension, dia tak boleh balance, dia jatuh. So bila jatuh, hip fracture pula. Okay, it will go on and on and on like that. So recommend memang kita tunggu dia dia punya BP above 160, 90 tu. Tapi okay, kalau dia ada underlying problem, macam dia ada underlying heart attack, underlying heart failure, underlying stroke, there needs to be a discussion between the patient and the physician. Okay, what do we want in this patient? Kita cakap tadi lah, adakah kita nak dia hidup lagi sampai 100 tahun? We need to have this discussion, what do we want to prioritize in this patient. Okay?
So in summary, it all goes back to quality of life lah.
Yeah.
What if sekiranya kalau patient dah start 160 lebih and we initiate treatment for them and the target is 140 in ESC and 150 in CPG if I'm not mistaken. Should we concern as well for their target organ ni? Atau
yes,
kita just focus on achieving the target saja?
No. Of course, we would want to prevent them from getting further TOD lah, target organ damage lah. But at the same time, like I said, kita kena weigh the benefit versus risk. Okay. Adakah dengan kita terlalu agresif nak capai target BP dia to less than 140/30, adakah ini akan membuatkan dia lebih risiko untuk hypertension? Kalau after you have that discussion with the family members, and then cakap, okay, family kata, okay tak apa, we have people to monitor dia at home. Okay, then fine lah, kita boleh teruskan treatment. Tapi if the patients are staying alone, old, frail, it goes back to what you want. Okay, adakah dengan kita tak memberi aggressive treatment, adakah dia akan develop another stroke? That is a question that you need to discuss with your family member and with the physician. Kalau both parties agree to be aggressive and to take the chances, the risk, then that's fine. We just treat. Kalau family kata no, I want to make it conservative, just let my father or my mother live with 2 agents, and hopefully with these 2 agents dia tak develop stroke or fall or whatever, then tu je lah, we go with that lah.
Okay.
Hmm.
My second question, Doktor, tadi Doktor ada sentuh pasal Tizat is tak boleh diberi kepada orang yang tengah ada gout. So what if in the case for control hyperuricemia, is it a go or no go?
Bukan kata tak boleh, it may worsen.
Okay, sorry, I may worsen.
It may worsen gout by increasing the serum uric acid. Let's say you have a patient who has gout.
Yeah.
Okay. Uric acid dia tinggi. Okay. Tapi memang dia dah lama ambil Tizat ni. Tak ada masalah pun. Tizat ni bukan contributing factor kepada increasing uric acid dia. Okay. Then I rasa tak ada masalah pun nak continue Tizat. Tapi contohnya dia tengah ada hyperuricemia, ada acute gout attack kan.
Yeah.
Tiba at the same time dia datang, dia masuk hospital, doktor pun nak start dengan antihipertensive, nak start HCTZ. Saya rasa at that point it's not a good idea lah.
Oh, okay.
Kalau baru nak start and at the same time dia ada acute gout attack, then it's not a good idea to start lah. Probably you settle dulu dia punya acute attack by giving colchicine and allopurinol and whatnot. Settlekan masalah gout dia dulu. Of course you can give other agent, CCB ke ACE ke yang tak can further worsen dia punya uric acid. Tapi kalau patient tu dah lama on Tizat and it's not an issue for him, I don't see there's a problem.
Okay, alright.
To withhold.
Thank you, Doktor.
Doktor nak tanya juga. Kalau yang tadi kan hypertension dengan heart failure reduce ejection fraction. Kalau yang preserve punya ejection fraction ada beza banyak pun.
Okay, with preserve ejection fraction, normally we evidence tu tak banyak lagi, tapi we treat kita treat sama macam reduce ejection fraction, the agents that we use, cuma tak ada mortality benefit lah.
Okay.
Kebanyakan mortality benefit like your ACE and beta blockers for your heart failure with reduced ejection fraction, for your heart failure with reduced ejection fraction. Sebab kita nak guna dua agent tu, ACE dengan beta blockers for reduction in mortality lah for heart failure. Evidence dia banyak kepada yang ada reduced ejection fraction lah. Yang preserve tu kita still treat tapi tak ada evidence, tak ada mortality benefit.
Okay, thank you Doktor.
Alright. Okay, shall we continue with severe hypertension?
Yes.
Okay.
Okay, can you guys see?
Yes.
Yes, boleh
Right,
tengok.
so moving on to the next subset, which is severe hypertension. Okay, so severe hypertension ni siapa ingat berapa BP dia?
180/110.
180 over 110. So it's stage 3, it's your stage 3 hypertension. It's above 180 over 110. So kalau patients with this BP reading, then he or she is classified under severe hypertension. So this is an emergency situation. Okay, bukan macam yang normal patient yang pergi MOPD balik for follow up, bukan. This requires prompt action lah. Okay. Now, so these patients may present in the following manner, okay, whether it's an incidental finding in an asymptomatic patient, okay, maknanya dia datang for another reason tapi bila check BP tinggi, above 180/90, so that's what you call incidental finding. And dia tak ada symptom pun, okay. Ataupun patient can come with non-specific symptoms, headache, okay, banyakkan lah kan, kalau kita sembang dengan our relative yang ada hypertension ni, dia akan cakap dia pening sangat kan, headache, dizziness, okay, lethargy, or yang paling lagi teruk dia ada symptoms of acute target organ damage lah, acute heart failure, acute coronary syndrome, acute renal failure, okay, or stroke, hypertensive ANCAF or dissecting aneurysm. So kita nak elak daripada benda-benda ni berlaku kat patient tu lah, tapi kadang-kadang it happen. So dia datang sebab dia ada ACS, bila kita check BP dia tinggi 180/110. Okay, ataupun dia datang stroke, check BP tinggi. Okay. So why do we see these patients? Okay, what are the common precipitating factors? Okay, majority of the time it's because it's non-adherence to the medication. Okay, patient tak ambil ubat. Seminggu dia tak ambil ubat, seminggu dia pergi bercuti, they forgot to bring the medication. So most of the time lah, kalau you all yang kerja dekat ward, yang tu lah yang korang selalu nampak. Okay, dia pergi holiday mana-mana, dia tertinggal 1 week of supply ubat, balik-balik BP skyrocket high. Okay, or it can be due to lack of family care or physician care. Okay, kadang-kadang anak beranak tak ambil berat, tak sentiasa tanya parents dia, you taking or not your medication, or patients have no regular health checks. Okay, banyak jugalah kita ada kategori patient macam ni, dia default follow up. Okay, tapi kesian, default follow up pun kita kena tahu juga why. Okay, is it because age factor, is it because tak ada support from the family, because patients yang dah tua ni, elderly ni, they sometimes especially yang dah kena stroke ke macam mana kan, they cannot move on their own, they need support, family support to bring them to the hospital. So bila nak family support ni, there's a lot of other social issues. Anak duduk jauh, tak ada siapa nak bawa, parents duduk sorang-sorang kat kampung. So these are the things yang boleh menyebabkan their disease management is not optimized lah. Or subtherapeutic management. Maknanya patient tu dah on amlodipine forever and ever and ever. Daripada 10 tahun yang lepas sampailah 10 tahun yang kemudian dia on amlodipine sahaja, dia orang tak step up treatment. So it can be it can worsen dia punya BP lah. Right. So categories of severe hypertension, okay, there are 3. Asymptomatic severe hypertension or hypertensive urgency or emergency. So the second and the third one is also referred as hypertensive crisis. Okay. So the specific management, okay, the aim of drug therapy in patients with severe hypertension is to reduce BP in a controlled, predictable and safe manner in order to avoid acute coronary, cerebral or renal ischemia. Okay, we need to do it carefully. Or kalau patient tu dah ada ischemia, contohnya stroke, okay, or heart attack is already present, you need to avoid it from further aggravating the situation. Okay. So in hypertensive urgency, okay, these include patients with grade 3 or 4 retinal changes, okay, also known as accelerated and malignant hypertension, but with no overt organ failure. So BP dia tinggi above 180, 110, tapi dia hanya present with grade 3 or 4 retinal changes. So sebab tu kita nak tengok, kita buat fundoscopy lah. Okay, nak tengok whether dia in this category or not. Tapi dia tak ada overt organ failure lagi. Okay, so these patients may need admission. Okay, may need admission. Okay, and a BP measurement should be repeated after 30 minutes of bed rest. Okay, and initial treatment should aim for about 25% of BP reduction over 24 hours. Okay, but no lower than 160/90. So ingat tadi kita cakap even though BP dia tinggi, tapi kita tak boleh terlampau agresif nak lower the BP because we don't want them to get ischemic event pula lepas tu. So kita kena, we should aim. So adalah cara dia nak buat, you need to reduce your BP 25% over 24 hours. And in these patients, oral drugs are proven to be effective and combination therapy is often necessary. So what are the oral drugs that we can use? We can use captopril, nifedipine, labetalol, okay? Where these drugs have a quick onset of action, about half an hour, okay, for captopril and nifedipine. Labetalol ni lambat sikit lah, kalau oral lah, okay, and the duration is about 3 to 6 hours. Okay, we can repeat giving every 1 to 2 hours lah. Okay, clear. Hypertension urgency, we can give oral drugs. BP should be reduced 25% over 24 hours. Okay, and we can use oral drugs. Now, in hypertensive emergency, this is ni emergency lah, so we need to act quickly lah. Okay, patient ni dah come with a complication dah. Okay, such as dia dah ada heart failure, dia dah ada sama ada heart failure or dissecting aneurysm, ACS, hypertensive NCAF or subarachnoid hemorrhage and acute renal failure. And this patient should be admitted. And BP needs to be reduced rapidly. Tapi rapidly pun ada cara dia lah. Taklah terlampau rapid. So it is suggested that BP to be reduced by 25% depending on the scenario over 3 to 12 hours. Okay, but not lower than 160/90. Sama macam urgency kan. Tapi in emergency kita reduce BP 25% tapi over 3 to 12 hours, half a day macam tu lah. In urgency kita lambatkan 24 hours lah, but in emergency between 3 to 12 hours. And you need to give IV drugs lah. Okay, apa contoh IV drugs macam ni lah, labetalol, GTN, azoxybate dan nitrate-hydrolazine. Okay, bergantung kepada patient punya underlying condition. Macam kalau dia ada heart failure, you need to be caution lah kalau nak guna labetalol. And kalau patient tu ada underlying ACS, biasanya kita guna GTN lah. Okay, ni so on and so forth lah. Icatibine esmolol ni rasa jarang guna kat Malaysia. Kita banyak guna ni lah, kita banyak guna labetalol dengan GTN. Kalau sesiapa yang kerja ward, betul tak?
Betul.
Azoxybate pun guna juga.
Gunalah. These two agents ni, azoxybate dengan GTN ni more preferred in patients yang ada ACS. Okay, cumanya GTN ni dia punya duration pendek sikit lah, 3 to 5 minutes, whereas azoxybate ni panjang sikit duration je. Onset lebih kurang, dua-dua cepat, fast acting, but if you give GTN, you need to re-administer up to 5 minutes and so on and so forth. Kalau azoxybate 1 hour lah. Okay, so ini like a table showing comparing between emergency and urgency. Like I said just now, dua-dua some emergency may have symptoms. Emergency are presented with symptom, but urgency no or minimal symptom. Target organ damage ni definitely ada dekat emergency, but urgency tak ada. BP reduction rate is minutes to hours in emergency, whereas in urgency hours to days. Of course, you need to evaluate for secondary hypertension. So this is the flow chart of how you need to manage hypertension emergency. Okay, emergency tu yang the severe form lah. Okay. So again, bila patient comes with above 180, 110, you need to assess whether dia ada target organ damage ke tak. Okay, kalau ada, is hypertensive emergency. Kalau tak ada, is urgency. Okay, kalau ada, you need to assess whether, ini doctors lah akan buat biasanya. Dia akan assess lah patient ada aortic dissection ke tak, severe eclampsia, bla bla bla. Kalau ada, reduce BP in this manner. Kalau tak ada, you reduce BP in this manner, like your normal way. Okay. Now, why is it dangerous to reduce BP in a rapid fashion? Because, okay, rapid reduction of BP in asymptomatic severe hypertension or hypertensive urgency is best avoided as it may precipitate ischemic events. Because kalau kita terlampau cepat reduce dia punya BP, oxygen supply dekat the vital organs tu tak ada. So it can cause another ischemic event. So that's why we need to do it in a very in a fashion, dengan cara yang betul lah. Okay, tak boleh terlampau cepat, tak boleh terlampau lambat. Okay, oral or sublingual drugs with rapid onset of action can result in an uncontrollable BP reduction. Okay, and several serious side effects have been reported with the administration of sublingual fast-acting nifedipine, and therefore is no longer recommended. Okay, following stabilization of patient's BP, subsequent management is tailored towards achieving optimal control. Okay, habis. So these are my references. Now, before we end, I nak discuss a bit on the case and I nak you main quiz kejap just to assess your understanding. Okay, so siapa nak baca? I think this is an easy case. I don't know. Can I have any volunteers?
Okay, boleh je saya baca. TJ is a, baca statement ni kan?
Yeah.
Okay. TJ is a 45-year-old white woman with history of type 2 DM with macroalbuminuria treated with glucoside 60 mg OD. She presents to the clinic for routine follow-up for diabetes. Vital signs include BP average 2 readings is 138/88 and heart rate is 70 beats per minute. Her lab result, sodium 140, potassium 4, chloride 102, bicarb 28, and blood urea nitrogen 40, creatinine clearance 45. Of note, at her last visit, her BP was 136/85. Which one of the following is the best for managing hypertension at this time?
Alright, guys, can I know what your what do you think is the answer? Should we just begin lifestyle modification, or should we begin lifestyle modification and add amlodipine, or C, lisinopril, or D, atenolol? So what do you think?
I think it is C. Begin lifestyle modification and add lisinopril.
Okay, any other response? Okay.
Agree.
Anyone else? What do you think? Okay, tadi yang menjawab ni siapa?
Falah.
Falah, okay. Why do you think it's C?
Because it has renal risk. Tapi dia punya BP dia tu rendah je 138. Mungkin boleh start. Kalau ikut recommendation tadi dia macam may start pharmacotherapy kalau tak silap.
Yes, that's right. I think it's good that you recognize that patient punya BP ni is 138/88. Dia bukan hypertensive state lagi, betul?
Yeah.
Hypertension stage 1 is above 140/90. Okay. Dia punya last BP pun 136/85. Okay, dia belum in stage 1 hypertension. However, dia ada type 2 diabetes mellitus and dia dah ada macroalbuminuria. Dia dah ada target organ damage, betul?
Yes.
Dia dah ada DM dan dia dah ada target organ damage. So once the patient is in this category, we need to start treatment straight away. So of course you want to remove A punya jawapan ni, betul?
Yeah.
Nah, antara B, C dengan D, mana satu you nak pilih?
So we must start with SI or ARB.
So because ACE and ARB, they have benefits, especially in patients with PM, in patients with CKD. Tak silap trial yang trial yang bagi this result is the UKPDS, betul? ACE in patients with diabetes. So have a look at the trial and see. Tapi memang jawapan dia C lah. Okay, amlodipine, CCB dengan atenolol ni taklah because the patient tak ada underlying heart disease, betul?
Betul.
Amlodipine you can argue, tapi in terms of benefit dia banyak kepada ACE lagi lah based on evidence. Alright?
Okay.
So jawapan dia memang C lah. This is the reason lah. Okay? Alright. So thank you very much guys. So before we end, I just want to assess your punya understanding. Let's just play a quick quiz before I let you go. Sekejap Okay ke you all?
Okay, doktor nak tanya pasal early screening tadi doktor cakap ada pakai dekat hospital mana?
Saya tak sure, sedang tu.
Okay, because I just for sharing purpose lah, because I think for KKM dia tu kena minta KPK, but I'm not sure about military hospital and community pharmacy ada jual ke tak.
No, we don't have here in military hospital.
Okay, thank you. Thank you for the update. Sekejap korang, bear with me. I nak ni dekat Kahoot tapi dia nak suruh upgrade lah pula. Alamak, kena upgrade lah. Nantilah I post the link to the quiz dekat Google Classroom lah. I need to check the setting. Okay? Alah,
Alright.
Penat je buat okay, any questions? Kalau tak ada, before I let you go.
Doktor nak tanya pasal emergency and urgency as well lah. If we achieve the 25% of reduction but not below than 160 of systolic, kita just discharge dia macam tu saja ke, atau we need to monitor dia lebih lagi ke sampai dia punya BP back to normal?
Macam mana? Of course, I think dekat hospital they will keep the patient until the BP is at the target range lah. Tak discharge lagi. Selagi BP dia tak in the target range, less than 160, 90, dia tak akan discharge lah. Because if not, if you discharge the patients too early, kita takut the patient will have another stroke ke, another ischemic event ke. Most probably patients yang ada hypertensive emergency ni, they'll end up staying in the ward for about 5 days, 1 week. Just to get the punya BP stabilized before we let them go. Kalau if we let them go without BP at the range, then you are putting the patient at risk. Tapi sekarang rasa COVID kan, banyak restriction lah. Banyak restriction. Dia nak apa ni? Prioritize COVID patient. Tapi hari itulah masa COVID tengah teruk kan. Sekarang ni dah slow down. I think it shouldn't be a problem lah. Masa tu patient yang masa zaman COVID yang teruk kan, patient STEMI tu duduk dekat ward dalam 3 hari je pun dia dah discharge, betul? Tak tahu lah, I dengar my friends lah cakap.
Doktor, yang tak boleh reducekan to not less than 160 over 90 tu, itu within 24 hours, right? Like after 2-3 days boleh lah kan?
Boleh. Yang tu in hypertensive urgency. Emergency 3 to 12 hours. After that, kita bolehlah teruskan lagi. Tapi slowly lah. Sebab tu kan patient-patient yang ada hypertensive emergency ni, dia dekat, kalau dekat ward, dia orang letak dia dekat acute bay. Betul? Yang paling dekat sekali dengan staff nurse punya station tu. And dia punya BP monitoring tu every half an hour dia nak check whether dia achieve ke tak dia punya goal tu. Okay? Right. Shall I, are we good to go?
Yes, doctor.
Alright, so if there's no other further questions, thank you very much. I will put the lecture notes in Google Classroom as well as the recording when it is available. Tapi sekarang ni for now, I will put the lecture notes dulu lah. Okay?
Right, thank you, doctor.
Alright, thank you so much. Enjoy your afternoon session in the class. Yes, welcome to Friday. InsyaAllah.
Thank you, Doktor.
Bye.
Assalamualaikum.
Waalaikumsalam. Have a great lunch.
Itu.